Welcome to AETCM, the emergency medicine channel. A 22-year-old female came to ER with alleged history of deliberate self-harm by consumption of rodenticide almost 40 hours before. On initial 10-second assessment, airway was patent, no pooling of secretions, and C-spine was normal. There was no any smell, any smell. Breathing-wise, bilateral air entry was equal. Respiratory rate was 20 per minute with a saturation of 100%. Circulation, BP was 118 by 60 with a pulse rate of 83 per minute. Disability wise, GCS was E4 V5 M6 with pupils bilaterally equally reactive. Exposure wise, temperature was 98.3 degree Fahrenheit and GRBS of 82 milligram per deciliter. On adjuncts to primary survey, we took a VBG and an ECG. VBG was showing pH of 7.39 with PCO2 34 and bicarb of 20.5. There was no any electrolyte imbalance and lactate was 1.9. Creatinine 0.74. Coming to ECG, ECG was showing normal sinus rhythm with a heart rate of 98 and QTC of 435. So coming to sample history, patient gives an alleged history of deliberate self-harm by consumption of morphine rat kill, 25 grams, 2 cakes she took. Content of which was mentioned to be bromodiolone on the backside 2 days back at around 11:30 p.m. Following which patient developed 5 to 6 episodes of vomiting after around 16 hours of consumption. She went to local hospital and was managed symptomatically initially. The next day, patient developed abdominal pain, headache, generalized tiredness and went back to that hospital where they did the routine blood tests and INR came to be 1.1. They gave patient the injection vitamin K 10 mg stat and referred the patient here for further management. Allergic history, she is not allergic to any known substance. She is a known case of...
Okay, I think we'll stop here and review. So we have an otherwise healthy 22-year-old who had history of deliberate self-harm, and the compound is reasonably clear for us by now. It is bromodiolone, which comes under the category of super warfarins. And she didn't present immediately. So the first report to a healthcare facility is 16 hours later. So let us assume a person like this comes to an ER immediately. So what are the things you will do?
If patient presents to the ER immediately, first of all, if within 1 to 2 hours if patient comes, we'll go ahead with gastric lavage with activated charcoal. That will be 1 gram per kg, maximum of 50 grams.
It's not gastric lavage with activated charcoal.
Gastric lavage and then we'll give...
Again, as you know, the activated, your gastric lavage is a little bit controversial kind of thing most of the time here. Probably, yes, definitely there is some role. So, you'll put in a large bore rails tube, and then activated charcoal. How do you usually give?
So with 50 grams at equal equivalence of water, we mix and we.
Okay, probably a single dose of activated charcoal might be okay here. What is multi-dose activated charcoal?
So it is usually used for poison toxins which are sustained release, which are prolonged activity.
So there you're going to repeat it like more frequently, 4 to 6 hours. You repeat the dose of activated charcoal. Here probably a single dose is reasonably acceptable. So okay, after that?
After that, sir, we'll collect samples like for toxicology, blood samples, urine samples, as well as lavage samples will be collected.
Okay.
Then, sir.
So here, by now we kind of know about the compound. So what are the probable tests you are going to consider from a toxicological aspect?
Sir, here we will go ahead with the rodenticide panel. Since patient consumed rodenticide, we'll go ahead to look whether it is a anticoagulant content or a non-anticoagulant content. And then, so we'll also go to look for the PT-INR of the patient. We'll need to monitor the PT-INR, the LFT, as well as we'll have to look at the electrolytes. Patient.
Okay, I'm just asking from the toxicological aspect, no? Okay. So any person, you're definitely going to collect all three samples. And here, since we have a specific suspicion, what we will be sending for, what they are going to do is TLC. Thin layer chromatography is what we'll be doing. And this can be run in all three samples, whether the compound's presence is there in blood, urine or the gastric aspirate. And again, remember that this is going to be a qualitative or a quantitative test?
It is qualitative.
It's just a qualitative test. Unfortunately, we may not be able to identify the exact level of toxin in either of the body fluids. Okay, so it is going to be a qualitative test. TLC is the method, right? Fine, continue. And depending upon the time period at which you are collecting is also important. Like, there's no point in sending in a gastric lavage after like 48 hours, right?
Yes.
Okay. So you collect the samples and you go ahead with your primary survey and assessment, right?
Yes,
Here, the patient is reasonably stable at that point. Fine, continue.
So sample history, she is a known case of hypothyroidism
Okay.
on Thyronorm 50 mcg. Last meal was consumed 3 hours back. On arrival to our ER, patient has only complaints of mild abdominal pain and no other complaints as such.
Okay.
So initially, sir, we sent for the routine blood investigations, and blood sample for toxicology was sent. The routine labs, like the report wise, sir, we got a hemoglobin of 13 with a platelet of 279. Total counts was 8.9, creat of 0.6. OTPT at initially was 38.7 and 30.1 with the INR of 1.32. Sodium, potassium, all electrolytes were normal, sir. Then we also did an ultrasound. Ultrasound was normal. Then we went ahead with a psychiatric consult for the patient, as well as a gastromedicine and a gastrosurgery consult. We started the patient on N-acetylcysteine, 600 milligram BD, and we started monitoring the patient for 12-hourly INR was repeated for the patient. On the second day of admission, patient develops a black color stools. So we started the patient on PPIs, 40 milligram BD.
Was a stool SOB sent?
So
or?
SOB was sent for the patient.
And
sir.
it was?
Sir, it was positive.
Positive. Okay.
And sir, we also started the patient on sucralfate, TID. During the hospital stay, patient's INR was getting monitored. From 1.3, patient's INR went up in the next evening to 1.45. We started the patient on vitamin K, sir, 10 mg OD.
IV.
IV OD 10 mg, and we continued monitoring. From 1.45, the INR fell down to 1.3, then it came to 1.32, then 1.2 and 1.15. The patient did not complain of any other symptoms during the hospital stay, and once after 3 days, once patient was stable, INR also came down. We decided to discharge the patient on oral vitamin K tablet for 1 week, and then review back after 1 week with INR and this results, and to repeatedly check INR every day.
Okay. So ideally, how long you should monitor the PTINR in such patients?
At least 7 days, sir.
Why?
Because
So basically, during the initial phase, you have the vitamin K reserves or the stores, right? For it to get depleted, it will usually take 3 to 4 days. So the symptom or the PTINR alteration usually happens after 3 to 4 days. Okay, why do you call it super warfarin?
because it is longer acting than warfarin, as well as action is prolonged.
Yeah, it's basically there is a synthetic change which is made. No, the phenyl group is converted from the traditional vitamin K, so it becomes more potent. So compared to conventional warfarins, your super warfarins are said to be 100x more potent in causing the anticoagulation effect. And moving on to rodenticide things, what is lethal dose 50? Any idea? These
Yes,
things
sir.
are supposed to have a marking of lethal dose 50. What is that?
So lethal dose 50 is used to classify the rodenticides, whether it is like very toxic or like less toxic. So accordingly, we divide it into whether it is if it is lethal, very toxic, it will be labeled as danger. If it is
So what is this LD50?
toxic,
LD50 basically means that
is that the dose at which 50% of the
perfect
population
of the target rodent is killed. Okay, fine, good.
So we'll divide it according to danger, warning, and caution. Danger will be the most toxic. Warning will be moderate toxic, and caution will be minimally toxic.
Right.
So danger will be containing the content of thallium, sodium monofluoroacetate, strychnine, zinc phosphide. Warning will be cholecalciferol and alpha naphthylurea, and caution, that is the least toxic, will be super warfarin, warfarins, and red squill. All those compounds.
Okay. Then can you tell anything more about rodenticide?
Yes, sir. So basically,
What's the most common? I mean, though here we have a case of super warfarin, and fortunately the patient didn't have much issues. But what is the most common rodenticide which we see, and what are the usual issues with that?
usually we'll see so zinc phosphide, aluminum phosphide, or phosphorus. Usually will be those compounds will be seen, sir.
Yeah.
Zinc phosphide, sir, minimum lethal dose is 50 milligram per kg. But if patient contains a direct ingestion of more than 500 milligram, that will lead to death. Other than that, the mechanism of action is that zinc phosphide or aluminum phosphide is converted to phosphine in the body, and then it comes in contact with any water, and then it will be absorbed into the blood and circulated into the stomach and intestine, and gets accumulated in the liver and lungs.
Right.
So that phosphine gas is which causes the toxicity in the body. So then aluminum phosphide, the fatal dose is 150 to 500 milligram. This clinical features occur within 30 minutes of ingestion.
Right.
So clinical symptom wise, initially the patient will be having nausea, vomiting, hematomesis, retrosternal chest pain can be there, abdominal pain will be there, followed by patient can go into circulatory collapse, refractory shock, hypotension, pericarditis, pulmonary edema. Also the patient in phosphide toxicity, they will be having hypokalemia, hypomagnesemia, and elevated lactate can be there in ABG with hypoglycemia. Then sir, coming to white phosphorus, which is another toxic component. So it will be basically minimal toxic lethal dose for white phosphorus is 1 milligram per kg. The clinical features appear in like 3 stages here. The initial stage will occur in minutes to hours. The patient will be having perioral, mucosal, skin burns, vomiting will be there, diarrhea. There will be a garlic odor from the breath. And there can be phosphorescent emesis or blood. After that, the patient goes into a latent stage. For like for 2-3 weeks, patient will not be having any symptoms. After which the third stage comes, that patient can be having multi-organ dysfunction can be there.
Right.
Kidney, brain, heart, everything can be injured. Usually, these patients, they have hyperkalemia with hypocalcemia and hyperphosphatemia.
Okay.
And these patients are usually started on N-acetylcysteine because they have tendency to go into liver failure. Other than that, sir, other classes are superwarfarins. Superwarfarins, namely, it is actually vitamin K 125 epoxide reductase inhibitor.
Right.
The usual components are, sir, they are brodifecum, diphenadione, chlorophacinone, and bromodiolone.
It's not the contents, different types.
Different types of
superwarfarins. Yeah.
Superwarfarins. They usually inhibit the synthesis of factor 2, 3, 9, 2, 7, 9, and 10. In the body. These are also known as single dose rodenticides because their action is prolonged, and in one dose they usually get killed. These symptoms usually, sir, onset is after 36 to 48 hours, so patients need to be observed for a longer period of time. Single ingestion is single ingestion 0.1 mg per kg will produce anticoagulation, but if ingestion is more than 15 milligram per kg, it is going to be fatal. Symptomatic. Usually, we start vitamin K if the INR starts rising more than 1.4. Below 1.4, we can observe, and prophylactically, vitamin K is not to be given because
that is with the here again with superwarfarins it can be a little logic. So conventional your rodenticide poisoning with ALF kind of symptoms, probably we are waiting. Why are we waiting?
Fulfill that.
That is one of the criteria. So what is ALF?
Acute liver failure, sir. Any patient presenting with altered sensorium in the last 22 weeks with symptoms of with OTPT elevation.
OTPT elevation need not always be there, no? I mean, OTPT elevation is basically your acute hepatitis, okay? So, there should not be any chronic liver issues. It has to be an acute insult to the liver, plus new onset high NR elevation or encephalopathy, right? And again, it has 3 classifications, right? What are the 3 classifications? Acute, subacute, and?
Acute and chronic.
No, that is ACLF. Okay. So there will be basically you have three classifications: hyperacute, acute, and subacute. So okay. So here usually what category this will fall into rodenticides? It will be usually it will be in acute or hyperacute kind of liver failures, right? So basic anything? Yeah. So what are the other therapeutic things you are going to consider? So basically you have this,
Yes.
you have a temporal relation of an toxic ingestion along with liver failure setting in. So what will be the usual definitive treatment will be a liver transplant most likely. So in peripheral centers, what should they should be aware of is a timely referral to a transplant center and start the workup upfront. So that will be the key message for patients who are presenting with ALF with thyroid design. That said, what are the basic investigations which needs to be done in ALF?
So LFT, PTINR, then RFT, then other than that, total normal routine investigations, total counts, CBC, CRP.
What's the role of ammonia?
Ammonia, yeah, so because of this hepatic NCAF to fill the King's College.
What is the pathophysiology of ammonia in ALF?
Basically, ammonia, it can't cross the blood-brain barrier. If it crosses, then it causes inflammation inside the...
So basically, the ammonia is converted to urea by your liver. So your liver goes into failure. Now the other systems has to clear the ammonia. So what are the other two systems which will help in clearing the ammonia? It is going to be a skeletal muscles and brain. So again, skeletal muscles become saturated. Now it is up to the brain. So in the astrocytes, it got converted into glutathione, glutamine, I believe. So basically, because of that, the improper conversion of ammonia, the brain cells get swollen up. So that is the basic pathophysiology where your cerebral edema is going to set in and the patient is going into encephalopathy. Fine.
So King's College criteria for liver transplant if you are considering in any acute liver failure patient.
Right.
So we have the liver failure induced due to acetaminophen or it will be due to other causes of liver failure. If it is paracetamol induced, the criteria is like the arterial pH should be less than 7.3 or there should be grade 3, grade 4 hepatic NCAF with prothrombin time more than 100 seconds with the creat of more than 3.4 milligram. If there are other causes of liver failure, the PTINR should be more than 100 seconds or any three of the following. That is, age should be less than 10 or more than 40 years. Etiology should be any non-A or non-Hep B, non-A, non-Hep B, and halothane hepatitis, idiosyncratic drug reaction. Then duration of jaundice before encephalopathy should be more than 7 days, and or PT should be more than 50 seconds or bilirubin more than 18 milligram per deciliter. So,
right.
Other than that, sir, other investigations that we consider in cases of rodenticide poisoning. So we look at the ECG. If there is QT prolongation in the ECG, it could be indicative of either arsenic or white phosphorus poisoning. If there is hypocalcemia, it could be either white phosphorus or it could be sodium fluoroacetate. If lactic acidosis is there, it could be either zinc phosphide or sodium fluoroacetate. If hyperphosphatemia, usually it is white phosphorus. Hypokalemia, zinc or aluminum phosphide or barium carbonate. And any radiopaque substance in the X-ray in X-ray abdomen, it could be either arsenic, thallium, or barium carbonate. And increased liver enzymes, creatinine, it could be thallium, phosphorus, zinc, or aluminum phosphide.
Right. So, any role of investigation called TEG, thromboelastography. So, basically, in all ALF, now the gold standard is to go for transfusion guided by thromboelastogram. And what is the choice? Is it going to be your cryoprecipitates? That has been completely replaced by PCC. So the choice of transfusion again for coagulation correction is
PCC.
Yeah,
Four-factor.
Okay, fine. And here, these kind of situations, the etiology is also very clear. But when you have a hepatitis with unknown etiology and a patient is in ALF, is there any other definitive test to prove the etiology of hepatitis? That will be like, what are the usual workups with an ALF? In an ALF, what are the different etiologies and what are the usual workups? Just let us quickly run through that. Most common is
viral hepatitis.
Yeah, viral. What all viruses?
Hep B, Hep C, Hep A,
Hep
Hep
B, C, D, E, and then continue.
Other than that,
Virus. CMV, HSV12, EBV, dengue, adeno. Okay, so those are the basic 10 viruses. Okay, then after the viruses,
any drug toxin
okay,
induced.
you have your paracetamol and then you go for the DLA, drug-induced liver failures. What are the common drug-induced liver failures you should be aware of? Common uses? ATT induced, anti-epileptics, those kind of drugs. Then, so you are done with 2. What else? Next will be Others can contribute. Okay, drugs over. After that, ethanol, ACLF, more of, not like ALF. Right, then
Infection.
autoimmune. Next comes in autoimmune. What about autoimmune etiology? Primary hepatic autoimmune related to other things. Okay, then other toxins like acetaminophen, we told, other toxins like mushrooms, other alternative medicines, herbal, toxicity, and all those things. Then pregnancy.
Yes, fulminant
What are the two things?
hepatitis
HELP
B,
and
pre-
acute fatty liver of pregnancy, AFLP. So HELP and AFLP in pregnancy. Then any other? Did we miss anything? Over. Poisoning we told, primary liver we told, autoimmune we told, other infections, yes. Then yeah, very rare causes. Then we will move on to other causes like direct infiltration of malignancy, lymphomas into the liver and things like that can also present with ALF. Okay. Yeah. So those are the basic causes. So we are talking about situations where we have a patient in ALF and the diagnosis is not proven. Usually the gold standard always remains a biopsy, and we cannot usually go for a transcutaneous biopsy. That is one situation where transjugular. So you have to go for a jugular and you have to take the biopsy. So that is one thing everyone should be aware of. So you have an ALF, diagnosis is not definitive, biopsy is needed, it is not transcutaneous, it is transjugular biopsies. Fine. So that is needed to prove the diagnosis. And other supportive investigations we have told now. So moving on to the management of ALF. What are the key factors?
If patient is in acute liver failure, once we have to, patient has chance of going into recurrent.
Let us keep it simple. So first is the diagnostic specific treatments. So we have told about a lot of etiologies. So in acetaminophen you have your specific things like your NAG, antivirals whenever possible, and depending upon the etiology, specific management is there. Remaining things are all supportive with management of hepatic encephalopathy, coagulopathy we told how to correct. Once a patient goes into a grade 3 or grade 4 and encephalopathy, definitive indication for intubation, and management of intracranial pressures to keep it low. So there are a lot of other strategies to keep the intracranial pressures in target, including your head end elevation to optimal ventilatory strategies to hypertonic salines. Okay, other hepatic encephalopathy measures. Okay, then those are the basic things. And also again, hyperammonemia itself can be an indication for RRT, renal replacement therapies. Okay, so the metabolic and also the metabolic corrections. Then definitive workup for transplant and like this. Okay, and medical legal aspects. Here we have. So ideally, if it's a suicidal intention, should be informed.
No, actually, no.
But yeah. So be aware of those things also. In such kind of patients, the medical legal aspects should also be covered. Right? Anything else? Anyone want to add anything? No. Okay. Thank you.